All right, so thank you everybody for joining us for today's panel on harnessing healthcare. And my name is Alana Goldbrin. I'm a director at PwC in our artificial intelligence practice. I don't, from full disclosure, work in the healthcare space, though I work proximate to the healthcare space at times. And I think like everybody else, I've been keenly watching everything happening during the COVID-19 outbreak and trying to figure out how I can use my own skills and my own talents in order to address issues with the pandemic. But I am very fortunate enough to be joined here by three panelists who are actively doing things to make our hospital systems better and work more efficiently during this space. I will let them go one by one to introduce themselves. Andrew, do you want to go first?
Yes, my name is Andrew Morris. I'm the Chief Enterprise Architect at Children's Hospital Los Angeles. I've been here just over 3 years. To provide a bit of background, one of my roles is to ensure that our IT solutions can help CHLA meet our strategic objectives. I'm actively working on our 3-year IT strategic plan as well. In the past, a lot of my work has been around significant infrastructure upgrades, upgrading our network, replacing our server infrastructure, building a new data center, and modernizing our security platforms. These efforts were just wrapping up in the early months of 2020. When COVID started, our CIO appointed me to coordinate our IT response during this crisis. So I collaborated closely with our clinical, quality, and administrative staff. IT served as a very close partner in this rapidly changing environment, and I was a central role in that response.
Thank you, Andrew. We're super happy to have you here. Tracy?
Oh, hi. Good evening, everyone. I'm Tracy Donegan. I'm the Chief Information and Innovation Officer at Martin Luther King Jr. Community Hospital. I was there, the hospital opened in 2015. I started just as Dr. Frencher was saying earlier, we were part of a small core team to build the hospital, and I was a consultant then and had left and came back as CIO. We're very excited. You know, we just finished our 5-year plan last year, and we're embarking on our next 5 years and focusing a lot more on population health and our ambulatory services, building out that and our medical group. So we have a lot going on. With COVID just struck, we were just opened up a medical office building, and it was probably the week before. But we handled it very well. I'm very proud of the organization on how we fared through this crisis, and looking forward to the years ahead.
Thank you, Tracy. Todd?
Hey, everybody. I'm Todd Davis. I'm the Director of Advanced Analytics at Cedars-Sinai. I've been here for about 2 years. Prior to that, I was in pediatric healthcare along with our partner over there, Andrew. I was at Children's Healthcare of Atlanta for 22 years. At Cedars, I lead a team of 4 data engineers and 4 data scientists that build and support hybrid analytic infrastructure and machine learning models to inform hospital operations and clinical care. Some of the interesting projects that we're working on now, census prediction, OR case predictions, predicting flu onset, and for an application we call FluView, spine surgery outcomes, and of course, everything COVID since February. The team that I have combines DevOps and data ops to build supportable, maintainable analytic infrastructure and resilient pipelines for hospital analytics. So happy to be here. Look forward to your questions.
Thank you, Todd. I'm really honored to have the 3 of you here today, and I have a set of questions that I'm really excited to go through, but just wanted to mention to the audience, we do have a live chat open. So if you do have any questions for any of our panelists, please feel free to enter them. I'll try and reference a few of them as we go through, but we will have some time reserved toward the end to answer and address these questions. So I think the way I'd like to start is really thinking about the data. I think as this outbreak started, as a general public, we became really acutely aware of this curve. This curve was mentioned everywhere through all of our media sources by our government, and we had mantras that everybody was saying we had to do whatever we could to flatten the curve. And I personally remember refreshing pages like Johns Hopkins dashboard and the IHME webpage, which was looking at projecting out the propagation of the disease and the outbreak throughout the various areas. I used to travel a lot for work, so I was not just worried about California, I was worried about a lot of other places. And even at my firm, at PwC, we were building COVID-19 outbreak models to help some of our clients figure out how they might have to navigate this crisis within the healthcare space, but also outside of the healthcare space. So I guess my question, and Todd, I'll start with you, given your function in the advanced analytics space, is how did your team respond to this immediate need for data and analytics in the early phase of COVID?
Sure. I think like every hospital, we struggled mightily in the early days. How are we going to track this new disease in our EMRs, depending on which flavor you have? And so that was a big deal for analytics, because it wasn't just like predictive analytics that my team mostly focuses on, but it was just stock standard reporting. What nurse, what doctor went into what room with a patient, and what stage of COVID were they in? All those questions were immediately important, and it took time for us to figure out how we were going to track those who had COVID. So it started off with patient notes, and then it migrated to tests. Of course, we were very short of tests in the early days. Not everybody got them. Some people had to go to the county only. Some people came to us. Then, of course, hospitals started setting up tents to do testing, and then the blood tests came out. So as all of those different methodologies of capturing COVID patients and defining them in the systems, as all of those were incorporated on weekly basis, we built a table in both our purchased EMR systems database, as well as our enterprise data warehouse that we cultivate locally, to make sure that those were the literal source of truth for this very important tracking, right? We couldn't report one thing to the state and another thing internally. All of our numbers had to match, and the amount of focus that went into keeping track of these numbers was immense. So in addition to just tracking COVID patients, there was also an enormous effort that my team had around supply chain, because, of course, there was a nationwide shortage of supplies, PPE and things like that. So there was intense focus on making sure that those numbers were accurate as well, so that we could make sure all the nurses had the PPE they needed to take care of the patients. And then, of course, the last piece was there was initially everybody was setting up, what were our patient volumes expected to be? Were we planning for a few hundred extra, 1,000 extra, 1,500, right? And those were also it was really interesting to keep track of all that. Fortunately, we in LA didn't experience quite that high of a numbers, but it was all very important planning to do in the early times.
Yeah, I'll add on to Todd's last comment there that during the early stages, there were a lot of unknowns. And we actually had our own surge planning practice because we were kind of at the point where we were like, okay, maybe adult patients are going to have to come to the hospital because of inadequate supply. So we went through a very rigorous exercise of just potentially planning that kind of outcome. So there was a lot of uncertainty in the early days.
Yeah, and I'll add, I agree with all of you. The getting the data, reporting it to the various sources. Everybody wants a different piece of information. Getting that data extracted out of the EHR was an issue. Reporting supply inventory, things like that. But eventually we've got, we're in a groove now. But I think the big thing is you have all these different areas or places that need your reports, that need your data. They're all asking for the same thing and different things and slightly variations. So that has been a challenge.
We can't hear you, Elena. At least I can't. I'm sorry.
No, I can't do that.
Sorry, I put myself on mute. Can you guys hear me now?
Yeah, can hear you.
It's a video conference, so someone has to put themselves on mute. Tracy, just to expand on that point, there was a lot of misinformation, I think, very early on in this crisis. And as we're trying to get a handle on some of this data, it's really important to coordinate messaging that goes out, not just to the public, but also to staff within the hospitals. How did you and Martin Luther King Hospital organize to coordinate information dissemination at the beginning of the outbreak?
Well, at the beginning of the outbreak, one of the first things we do, and we do it at any type of situation, is we formed a hospital incident command center. And that was our way of creating a structure upon which that we had consistent communication, regular communication going out. We had a wonderful, we do still have a wonderful director of our marketing department, and her and the COO had put together a newsletter that went out quite frequently, a couple of days a week, that gave stats on what was going on, different messages to the staff, and reminders on the proper way to wear PPE and so forth. So that was our way of making sure that we had consistent and frequent communication, organized communication coming from one place.
Yeah, I'll add to Tracy's comments there. Fortunately, we had just recently instituted daily bed huddles among the nursing staff, and it was not just a couple of nurses and nurse leaders that showed up. It was 60 plus people every day, and this was just for normal operations. This was instituted around December of last year. And so we ended up tacking on an extra 30 minutes for COVID issues, an hour sometimes in the early days, to do exactly that, to come up with the issues where doctor advice and nurse advice differed. How do we resolve those things very early? Shortages on PPE, how can we move it from one floor to the other? It was critical in dealing with the early days where there was so much confusion and information coming in that was potentially conflicting.
Yeah, we did the same.
Andrew, just to complete the circle, did your hospital also institute a command center?
Yeah. So for those who are a bit unfamiliar with healthcare organizations, every hospital has an emergency operations plan that details what to do, emergency command structures, responsibilities, and protocols. And in general, those structures have very common roles, but they can be dynamic depending on the nature of the emergency. So for example, like a fire in the facility is very different than like a localized leak in a specific department. And so every hospital has a command center that scales up or scales down. In the case of COVID, it required a very large command center. Our chief medical officer, Dr. Stein, led that, partnered with our hospital leadership, our infection control team, quality department, epidemiologists to lead the command center in what became a multi-month operation. So the command center brings all these key leadership, decision authority, and the data to the table so that they can act rapidly and maximize patient and staff safety. Our nursing teams, IT, lab, facilities all worked very quickly to ensure that we had screening, in-house testing, and contact tracing processes in place. It was a concerted effort throughout the entire organization. I do need to call out that data was very key to the success of the command center. As Todd and Tracy have both said, their organizations are very similar to ours, very data-driven and prideful of that fact. We track city, county, and state infection rates. We developed our own testing capabilities, I think in mid-March. It was early in the process with our lab for internal use of our staff and patient testing. And then we maintained dashboards, shared that with leadership. I think twice a week we had meetings, and that data, leadership, and communication really made this particular command center highly effective.
That's great. Was there any data sharing instituted between the hospitals? Or was that not necessary because you're all working off more or less the same?
We were collaborating with the county in our case.
Yeah.
Yeah,
same.
That's good to hear. I want to come back. I think this topic of command center is really interesting, and Tracy, the way you were outlining it, it seems like they have a really broad remit in terms of the control that they institute on the organization. what functionality did the command center have to moderate patient flow throughout the hospitals, or what changes did they institute in order to stem unnecessary visits?
Well, there was you could think of it in I guess, 4 ways. I mean, you had the patients flowing into the hospital in the ED, so we had to solve that, and I can explain that in a second. We had the clinic volume. We had to secure the entrances, so we had one central flow into the hospital, and then you also had to, sort of understand and the nature of the calls coming into our switchboard and call center. So those were the 4 areas. On the patient flow piece in the hospital and in the ED, we really had to understand how the patients were going to present, that whole process of triage, where to put the patients, the PUIs, patients under investigation, where to hold them, and how to protect the staff and the rest of the patients from exposure, how to limit the patients or the hospital staff going in and out of the tents, how to just secure that and narrow that down to just the healthcare providers with the direct patient care, and that required technology as well. On the clinic side, as you heard the other panel talk a lot about, it was all about telemedicine. And then in terms of the call volume coming into the hospital, we put a chatbot out on our website to give up-to-date COVID information and to help with the screening and navigation around to the appropriate, sites of service, 911 or ED, or a link directly to telemedicine.
Great. It seems like there are a lot of technology-oriented solutions that have been supporting not just moderating patient flow, but triaging care and trying to provide patients and staff with the relevant information that they need in order to get through the hospital and the pandemic effectively. Andrew, I'm curious from an IT standpoint, what type of innovations was your team supporting?
So for those who don't work in a hospital, a lot of the staff are nurses, and nurses work 12-hour shifts, and 7 a.m. is the time when shift changes for us. That's good for efficiency, but the challenge is when you have a large influx of staff coming at once, the screening process is very challenging. Initially, in the early days, we had a comprehensive set of questions, and I think we stationed maybe 12 nurses down at the staff entrance for the hospital to ask these 12 questions. And so, there was a line, safe distancing line, and it had both a lot of labor expense implications, as well as some significant delay in terms of people getting into their workday. And you imagine that workflow, and then you also have the same thing for patients through a separate entrance. So one of the things that our command center asked us to do is for us to develop a chatbot to help offload some of that bottleneck. The way it worked was you scanned a QR code, it takes you to an interview page, and you ask the questions, and then you show a color-coded response on the phone. And that dramatically had very positive financial impacts. Nurses could go back to actually doing their regular job. And it was also very beneficial for staff that would often have to line up to get into the facility. So that's one example. Another example is moderating safe capacity for outpatient clinics. So if you go into the hospital, you don't actually stay there, you just go for an appointment. That's outpatient. And traditional waiting rooms aren't really optimized for the 6 to 8 foot safe distancing between patients. So ensuring patient safety means you need some new processes. And the way that we do that is modifications to the schedule. You space the patient's appointment times farther apart in order to make sure that your waiting room is never too full. One way that we're planning to address this is wayfinding, where we're hoping to turn into a more comprehensive patient scheduling experience. So if a patient can be notified when it's time to come into the facility and navigate to their specific clinic, that will help offload the waiting room as a capacity constraint. If you think about that for a little while, though, what you realize is that moves the waiting room into their car. And that works very well for patients who have cars to wait in, but it doesn't represent equal access for our families and patients who come to our facility on public transit. So as a result, some of our longer term considerations are around when to leave your home as the objective. And we're in early exploration of this topic, but it's really important for our mission to have equitable access for children and their families.
Equity and access of care, I think, is historically has been a problem for a wide variety of reasons. And I think the push toward technology innovations to solve for certain problems can sometimes create new ones in this equity of space. And I think of telemedicine as a great example of that, where it oftentimes requires that patients have access to internet connections. They can access either through their home network or through their phone. And candidly, there's a significant disparity in Wi-Fi access around just the U.S., not to mention globally. And I guess, Andrew, we can start with you because we're kind of on the topic, but how have you guys been thinking about telemedicine and expanding that, but also considering the inequity in access?
So we've been very fortunate, and we experienced early success switching our outpatient clinics to telehealth. We rapidly mobilized a team to develop a standardized workflow for all the MAs and schedulers in 32, I think, outpatient clinics. And another team to ensure that all their devices and webcams met the requirements for our platform. We were fortunate to have secured the contract for audio-video conferencing solution in advance, so we didn't have to spend too much time legal on that. There are some challenges that I think are worth calling out. The first is that not all clinical visits lend themselves to a video visit. It's kind of intuitive in that some types of care require physical examination or special biomedical equipment. And so we found that aligns with our patient satisfaction scores on a per clinic basis. The second is a financial reimbursement model for telehealth. The fees collected cover a very, very small fraction of the costs required to provide the service. The reimbursement models need to be updated, and that will happen through hopefully government advocacy and perhaps negotiation with insurance providers in the coming years. But despite all the financial challenges and the logistics, we felt it was really incredibly important to get telehealth in place ASAP. With pediatrics specifically, there's not really such thing as an elective procedure or elective care. And deferred care for kids means usually worse health outcomes. So the deployment was complete mission implemented throughout the entire organization. And we partnered with our marketing campaign to make a PSA, sort of a public awareness campaign to ensure that parents understand that pediatric care is an essential activity. So whether it's virtually or in person, it's important to bring your kids in.
Tracy, has your hospital had a similar experience with telemedicine?
Yes, I mean, what with telemedicine is, as I think Dr. Frencher alluded to before in the previous discussion, we were on our path to enabling video visits, but we weren't quite there yet. We were just doing phone visits. So we had to turn this around rather quickly. And I think Dr. Shapiro said in his organization, it was like 2 weeks that they had to get it done. And we didn't approach it. I mean, we didn't have the luxury of time to approach it in the best way, meaning how does the patient, how best can the patient, what's the best way for a patient to virtually meet with us? There's so many factors that can come, to stand in their way. There's access to broadband and, ability to understand how to download and to turn on your microphone and, to get the right access approvals. All that stuff still has to be worked out and worked with the patient. There's so many questions to answer, but we had a similar experience. We had to turn around rather quickly, and now we're coming back to optimize it. So I formed a small telemedicine optimization group, and one of the first requests was we've got to get a patient on the panel eventually to help us solve the solution. That was one of the points that was made over and over again in the previous discussion, is the importance of really involving the end user.
So I agree wholeheartedly with what the panelists said about getting telemedicine ramped up and quickly. And spoke eloquently about the advantages that gives to our potentially underserved populations, or populations that don't have a way to access our services in the new way. Something that hopefully is not bad form to discuss, but it also turned our in our medical network, the physician reimbursement model sort of on its head, right? Telemedicine was a blip. I mean, it was in the margin of error as tracking physician metrics, right? And suddenly it became this enormous thing. And, you know, from the data and analytics side, we had to spend a great deal of time sort of after the early emergency was over on what are we going to do about what has happened with the care models that we'd all been depending on for, you know, so many years. So that work is also ongoing, but I agree with what Andrew said about working with government payers, saying this is likely to stay, and we need to come up with some realistic reimbursement models.
And Todd, what are some of the other ways in which the advanced analytics team has been supporting the hospital system in terms of identifying different improvements that they could make to existing processes, or evaluating some of these newer technologies?
So I talked a little bit in the beginning about what we did in the early days regarding, you know, how do we track COVID patients and keep up with how flagging somebody as having COVID, and then when they become better and when they get discharged. So I talked about that a little bit in the beginning. Once we became a little bit more mature, which it sort of feels like was in the July 4th or August area, once everybody stopped working, you know, 20 hours a day trying to get all this data and put together a data hub where everybody, regardless of whether they were a clinician or a VP, could come and find the data that they were looking for. So we ended up going more towards predicting what our COVID caseload was likely to be. You probably, UCLA had their model out there, LIMA, COVID Act Now, Columbia, a lot of different health systems were publishing their models. And we had our own model as well, because what we noticed in July was that our caseload started to diverge from the larger LA population for positive test rates and inpatient admissions. And so we needed to build our own model so that we could keep track of the patients who were likely to present at our facility. So that's really how we sort of started to mature the information that we were providing to the hospital. Like many hospitals across the country, when we thought our numbers might potentially be in the thousands and we're uncertain of that, the logical place to reduce services was in the surgical area. Surgical area contributes a lot of inpatients to the floors. And so like most other hospitals, we considered what could we do? How many surgeries did we have to reduce in order to potentially deal with this enormous influx of patients? Our models, once we realized cutting, you know, X number of surgeries per day impacted the inpatient population by Y numbers, we started to be able to say, all right, if as the surge waxes and wanes, and as we, you know, increase 10 COVID patients per week or 20 per week, and deal with the weekly variation, that we were able to be a week ahead, right? So we're not going to go from, you know, 800 patients to 1,000 patients in a day. That's going to take time to get there. So what we developed was a scheme to keep track of how long of a lead time did we need in order to start talking to the VPs that ran the hospital, the surgeons that run the OR, to start talking about our predictions for an influx of COVID patients. So that's really where we matured in our ability to compare all of these models along with our model and sort of take the best of that ensemble and talk about the various metrics that LA was keeping track of, and sort of what's happening in LA County for positive test rates, to really advise Cedars on how to both be able to conduct the surgeries, which were critically important, right? There was a lot of very sick people. You know, when they talk about surgeries that can be delayed, you know, a lot of those are terrible things that shouldn't be delayed. And the surgeons, our surgery corps was advocating very hard that, you know, these people might not live if they don't come in for these surgeries. So the key was figure out who we could take care of safely, get the system safe for these patients to come in, and bring them in and start having these elective surgeries that needed to be done. So that's where in the later days, we really sort of felt we added the most to the mission of Cedars.
And I guess now, as it seems like we might have another spike looming, given that we're impending in coming toward this winter time period. Doesn't feel like it in LA, but with winter, we tend to have second spikes of these. Have the practices at each of your hospital systems changed? No.
So we're keeping very close track of our current census and all the fluctuations that we're seeing. I mean, basically what the county is saying is, what we're seeing is after a very long, slow downward decline in inpatient admissions, that we're sort of bubbling around at the lower levels. And what we're watching mostly on the charts that we have is like sentinel events, like did we pass a barrier to opening up in restaurant dining or bars or sporting events, right? Those are the ones where people will be together in close proximity, potentially not wearing masks, that we're keeping track of. We have an events table for when any of those switches are being thrown, so that we can pay very close attention to what's happening in LA and positive with the test positivity rate and inpatient cases. Schools is the big thing. If UCLA or USC or the elementary schools, middle schools, once they fully open back up, those are the things that we're watching closely.
I'd just like to add, I mean, Andrew was saying earlier that, his hospital had, they're in the practice of doing capacity planning and surge planning all the time. And that's when you asked, has anything changed? And my answer was no, because this is just what we do. We constantly look at, like Todd was saying, what's going on in the environment, the infection rates, various, lifts in the community in terms of people going into restaurants and so forth, and that recent win over the weekend, I saw no one was wearing masks, but yeah, so we keep a close eye on that. We don't have a lot of capacity, so we're constantly in that mode of planning and forecasting.
So, Tracy, then what's different about this period then? If this is just kind of normal state for us, is always looking at what are the trends, what's happening externally, what are some of the challenges that you're seeing in terms of responding to this pandemic versus pre-COVID normal?
I feel like we're a hospital and it's just mode of operation where there really isn't a lot different. I mean, we've had to do a lot of different things in terms of isolating patients and keeping people safe. We've implemented a lot of technologies, even for people that even in telemedicine within the hospital between staff and with patients. So I don't really feel like there's a difference now. It's just exacerbated the problems or the trends that we had always planned to do. Telemedicine, self-service, better access, wayfinding, all of these things are just become even more necessary to give to our patients and our community members better access to what they need for their care.
Yeah.
There was a meme floating around on the internet at the early days of the pandemic that was saying, who in your organization is most responsible for your digital transformation? CEO, CIO, COVID-19. So
yeah,
so just feeling that more the same. Todd, from an advanced analytics standpoint, is there anything fundamentally different that you guys are doing today than you were doing prior?
There is, along with our daily nursing bed huddle, we also implemented a digital command center, which, if you think about it, most of the people in the hospital have access to the EHR, but not everyone. Not everyone who is involved in the patient flow has access to your EHR all the time. And so what we've built is a series of dashboards that keep track of the patient flow metrics and building in predictive metrics so that we can give the clinician and the house managers, the people who sort of control the patient flow from the ED to the floor to the ICU, the ability to, on a handheld device, view sort of what is going on in the hospital. So it contains a real-time census. It also has flags for patients who've already been, have orders written for discharge, their likely discharge time. It also shows queuing patients in the urgent cares or in the EDs who already have orders for certain floors and beds, and then says, all right, so in the past, patients have, with this ICD-9 or lab test values, are likely to go to these floors, and does that floor have any beds open? Also, the key is tracking delays to care or delays to discharge, right? So, you know, it takes, you know, some number of hours once the final discharge order is written to sort of work up everything you need to do for the patient before they go. But if there's like this one last radiology exam that's ordered late in the day and the patient is in the middle of the night, there's only one tech, but that otherwise that patient could go home, their family's already here. Those things are flagged up so that they can be, so that an intervention can be done, because not everything can be automated, right? And we can sometimes take patients who are ready to go and move them to the front of the line and then open up a spot for somebody who needs to flow into the system. So that's sort of it, not in its infancy, but it's barely a teenager. We continue to work on the predictive models to sort of help give that forecast for the clinicians to see out what's ahead of them.
And I'm just curious, how does your hospital get some of that data? Are there real-time feeds? Is it manually inputted information from individual hospital floors?
Yeah, it is. It's a combination. It's mostly real-time feeds from the EHR. We two different methods of doing that. One is sort of the brute force method, and not ideal. It uses a little bit older technology, but generally you're creating exports and then you're bringing them into an external data source and then using that data. But we now have probably 50% of our long-term streaming data system built where you're getting data from, for any inpatient in the house and any outpatient schedule for the day, you're getting basically everything about them. All nursing notes, all orders, all lab results. So the data is there and available to be reflected in a visualization tool or a dashboard or alerts. And on top of that, we're building an analytics infrastructure so that we can analyze that data as it's streaming through. And so that's really the biggest project that we're working on over the year, because batch analytics just aren't playing anymore.
Andrea, I see you nodding your head. Is that something similar to what you're supporting from an IT perspective?
Yeah, I don't want to talk about specific vendor products here, but yeah, we have one that's very, very closely linked to our EMR. And the more real time, the better is our perspective. And we're actually in the middle of an analytics migration because of that, moving away from the model of load it in, and the next day you get some data. That's not timely enough for our quality and clinicians. So that's what we're working towards.
And Tracy, for you as well?
Yeah, you know, we're on our journey in analytics. You know, we're not as advanced as Todd or Andrew, but we're definitely on our way. We're doing a lot, but we have a room to grow. It's an exciting journey, and it's complex because you have, like you said, multiple data sources. And even as we move towards more treatment in the home, more connected devices, it just strains the system even more. But I if you don't mind, I'd like to go back to this notion of a command center, because I really think it's a very effective method and has different applications. You know, Todd just sort of referred to sort of central spot for data, one place for physicians to access and other interested users. And you're going to see it more and more, and you've seen it in the past. There's command centers around capacity management. More and more command centers are being built for patients as a virtual hub. And I really like this notion of this central one-stop shop. We used it a lot when we were building out the hospital, and it was very successful in centralizing and having there's no questions on who you ask. It's just one place. So I like this concept, and I think you might see more and more of it.
It's effectively like a center of excellence dedicated towards specific capabilities.
Yeah.
You see other institutions, not in the hospital space, are also adopting center of excellences around analytics and AI and data for the same reasons, and robotics as well, because that way there's one entity that's responsible for building and scaling these applications, rather than having a federated model, which might have its own pros and cons associated with it. But I find that very fascinating.
It is in a way. I mean, let me just say, on the virtual hub for patients, it's a way of having one phone number to call. It's a call center, for example, that's staffed with nurses and care coordinators and customer service reps. It's just a great way of scaling, but also finding a one central place for patients to call. And plus you could have sort of an AI front end, a conversational AI front end, and on top of it to satisfy those who don't really want to call on sit on the line, but that's kind of what I mean.
Oh, cool.
Yeah.
And Todd, I just want to go back to one thing you mentioned, which was that you mentioned that your team is building some predictive models based on the data that you're getting out of these EMRs. What type of applications are you building?
So we do a traditional machine learning engagement with the clinicians. I mean, generally, they come to us with a problem that they need to solve, a clinical or operational problem. Something as simple as, what is our census going to be tomorrow is critically important, right? It was critically important before, it's very important now. But also clinical questions, right? So we have some work going on in the Women's and Children's Health Center, where we're trying to predict things like the likelihood of cesarean section, taking in things like fetal heart rate and real-time examination data, and working with some really astonishingly brilliant clinicians who are both near data scientists, but also have a medical degree. And so when they and my data scientists get together and talk, I usually just leave the room, honestly. But the reality is that it takes super smart people like that to figure out not just how do we get the number, right? Because in healthcare data science, I mean, good numbers are great, 90%, 95% accuracy, but is that the thing that the clinician needs at the point of care to fold into the calculus and make decisions? Because it's a lot more nuanced than just this perfect number, right? Because you can be, approximately right, and what level of accuracy is good enough, and what in the physician's mind or in the nurse's mind, and when you give them a number, is that like as good as a lab result value, or is it a suggestion? And those are all the toughest conversations around healthcare AI.
And I imagine the emerging space around explainability becomes increasingly important then to try and get clinicians on board.
Yeah, absolutely. Explainability, I mean, it's a conversation I have all the time. We hear from a researcher that might say, well, how come you didn't use a deep learning model? And we say, well, because decision trees explain this problem space much more simply than a deep learning model. A deep learning model, we might get a better number, but we might not be able to tell you why we got that number, right? And our experience in the healthcare space is that really just doesn't work. So it's a negotiation, and it's really the coolest part of the job that I do is how do we get to a place where the numbers that we give you help you make clinical decisions to take better care of the patients or the hospital.
Andrew, from an architecture perspective, as part of the IT organization, do you notice the system moving more toward adopting and scaling more machine learning models recently?
So our current level of focus is there's a couple different tracks, and that is a track that exists. It's within a different domain than what our primary focus is on right now, which is creating a connected care experience for patients once they're outside the facility, getting a virtual second opinion, getting access to video visits for any child on any platform, that sort of thing. We do have departments that are looking very closely at that, but for the most part, what we're doing right now is trying to get all of the data from the ecosystem of what people are doing. And so there's both doctors and entire departments that are working on aggregating some of that data. I think it was at Amazon reInvent 2019 when going to conferences was a thing. One of the Cerner executives got up on the stage, and he estimated that at Cerner in their data center where they have all these hosted clients, they have only about 20% of the actual indicators of people's health. And so getting the ecosystem, including weather, air quality, their heart rate, that kind of thing, that's the last frontier, but it's also really important to be able to help predict someone's outcomes or their status. So that's building this digital ecosystem and giving people access and to their own information is also another major area that we're focusing on, democratizing so they can see their own information.
Great. I do really quickly want to remind the audience that there is a chat available. So if you want to enter any questions for the panelists, please feel free to do so. Team, before I transition to the last question I have for you, Tracy or Todd, anything you want to add to what Andrew mentioned?
No, I agree. I mean, our focus is analytics are important. We have different areas in the organization that have done some models, and we've been using them to improve care. But for us, in terms of the areas I'm focusing a lot of attention on is just connected care, just like Andrew had said.
Yeah, it seems like the experience is really crucial too. That needs to be kept front and center, and other types of automated decisions or informed decision making can follow as long as they are all in service of that better care experience. So, yeah. Which as someone who potentially uses hospitals, I appreciate that. So, and so I think just to come back to our initial topic around COVID-19 and how you've all been adapting, the last question I would like each of you to answer is, of all of these technologies that hospitals have rushed to adopt and have incorporated into day-to-day practices around care and around triaging and monitoring and metering patient access, what I'm curious about is which of these technologies, if any, and maybe all of them, are here to stay, and what fundamental changes do you think your hospital will have to make going forward? Andrew, maybe we'll start with you.
I will qualify my views as my own and not representative of my organization. I think we've seen a trend in general in healthcare that there's been a deliberate move towards patient-centered care. And so that speaks to what I was referring to before, giving people access to their data, making it more accessible and available, and making it easier for them to make choices around the care they receive. I think that telehealth and virtual visits is a great equalizer for a lot of people. There's a lot of families in pediatric and adult healthcare that couldn't take half a day off to go to the doctor. And so I think what telemedicine delivers is going to be ultimately transformative if it can be sustained. And so that financial sustainability, as Todd and I both mentioned, is going to be key to fostering that in the future. I think that part, though, I have a very positive feeling about sort of the future of that direction. And it'll also be interesting to see, with the economic fallout that's happening. You have examples of 3 fantastic hospitals here. I don't know that that's largely representative of what's happening across America. And so I think there will be some larger industry shifts as well. Consolidation has definitely been the trend in the past, but we'll have to see.
Yeah, I agree with Andrew. I think the technology that we're talking about is definitely here to stay. But to Andrew's point, the most important thing is, revolving around the patient and the patient-centered care, and helping them engage in their experience, in their healing process, allowing them ways to develop relationships with their physician, have better access with their care, just getting them any technology that helps them achieve that is one that's worth investing in and really spending time on, and are those that are here to stay. One of the things I wrote down earlier that I just really loved that Dr. Frencher had said was that it's all about leveling the playing field, and but you can't just jump into that. Of telemedicine, for example, he used it's getting the patient involved earlier in the process, because otherwise it's not a playing field if it's not really addressing the way they need to access their care. So I guess in summary, telemedicine, AI, other analytics, remote patient care, moving patients, care to the home in the setting where they are instead of having them come to us is another big thing here to stay. Wearables, just all of that technology, anything to improve engagement and participation in care.
Yeah, and I hate to go last because they've picked the best things to talk about. So, I agree with telemedicine and remote work. Those are likely here to stay for whether it's 100% or some less than that. But I guess what I'll say is that I suspect that the best inventions and trends out of COVID are nowhere near being invented yet, and will likely come, in 2022 and after. And I'm looking very forward to that. But this did, it was like the can opener. Or what was the one you mentioned, Alana? Whether it's a CIO, the CTO, or COVID. COVID has proven a lot of things are possible and made us jump over that fence. Well, now that we're over there, it's what do we do with it?
That's great. I really appreciate the three of you for spending an hour and change talking to us about these topics. I've learned a lot. I hope the audience has as well. We've so far only had one question come through, Todd. That's geared toward you. This was earlier when you were talking about the projection models that the hospital has been making that your team is in charge of. And James is asking, how long into the future does your model hold up?
We've settled on two different model intervals, 7 days and 14 days. The reason we settled on those is, first of all, those are the ones that tend to be most accurate and supported through the other models that we're looking at. But also we paired that with our chief lever for influencing inpatient census, which is the operating room, right? So if we, as we did in the early days, as many hospitals did in the early days, dramatically reduce the number of surgeries that we do, we dramatically drop the number of inpatient census patients, right? So at 7 days and 14 days, we have lots of latitude to respond to even a sharp spike in COVID cases.
That's very interesting. Thank you for that. Any other questions from the audience? I don't see any others coming through, and I know we're up on time. So once again, Andrew, Todd, Tracy, thank you so much for joining this. I had a blast. I think that hopefully the audience learned as much as I did. I do want to remind the audience, as Todd is pinging me here to remind you all, that there are networking sessions that you can connect to on the left-hand side of the screen. So if you want to do any quick one-on-one video chats with other attendees or speakers, that's really the forum for you to do that. So once again, thank you guys for joining. I really appreciate it, and thank you to the audience for watching us. Hope you have the rest of them.
Thank you.
Thanks.
Bye-bye.
Everybody.